Great. So, I think we're going to go ahead and get started. I think there are some folks who are still signing in, and that's fine. But I want to welcome you all here today. Going to kick things off. My name is Louise Cohen. I'm the CEO of the Primary Care Development Corporation. For those of you who don't know us, we are a community development financial institution whose mission is to expand access to high quality, affordable primary care, especially for those who need it the most. I want to thank all of you who've joined us today and our panelists for this important discussion. So PCDC was started in 1993 as a public-private partnership with New York City, and we've since expanded to New York State and around the country. We have three pillars of our work. We lend to community health providers with affordable and patient capital. We have a consulting team who works to help practices of all different kinds to become high-performing, financially stable, and with excellent outcomes. And then we have an advocacy wing, which we think is really important. PCDC is currently working on a bill in the New York State Legislature to expand resources to primary care. It turns out that most people think that primary care gets about 50 cents on the healthcare dollar. But in reality, primary care really only gets about 5 cents on the healthcare dollar. And that was a study just published in March. And New York has a piece of legislation that's pending before the Senate and the Assembly, which is called the Primary Care Investment Act, and you'll hear about that a little bit more later in the program. But it would increase primary care investment, which we believe would lead to greater access for people who really need it the most. And we are not the only state that's thinking about this. There's about 25 states around the country who are working on some form of increased investment in primary care. Really, we're talking about here rebalancing the healthcare system so that it focuses on prevention and primary care. And we believe that will really change the trajectory of many people and communities' health, where they're going to be more able to successfully work, take care of their families, go to school, do the activities that they want to do. For many years, PCDC has been engaged in active policy research, I would call it, that provides insight into data on primary care access, utilization, and outcomes. We released something that we call the New York State Primary Care Scorecard last year. It's available on our website. And we've just released an interactive tool, which we're calling the Primary Care County Data Explorer for New York State. And that allows you to explore county level data, some of the data that's in the scorecard, as well as some additional data. And we're going to be talking about that in great detail today, because we believe that this tool will be very useful for you all in the advocacy that you do every day to promote primary care, and for practitioners, as well as stakeholders and policymakers, to be thinking about how it is that we can rebalance our healthcare system to move towards primary care. So I want to sort of turn it over to our primary researcher here at PCDC who worked on this, Angela Allard. She is a research and evaluation manager here, and she led the development of the Data Explorer and has authored many of PCDC's publications that can be found on our website. We also, in addition to sharing with you the Explorer, we're going to be having a panel discussion about the importance or the utility of this data and how best to use it by both PCDC's policy team and leaders from several federally qualified health centers in New York State. We'll have some questions at the end. We'll be available to answer those. So please put your questions in the Q&A, and we'll be answering them as we can throughout the course of this presentation. So I'm going to go ahead and turn it over to Angela for a discussion and demonstration of the Explorer, and then we'll move into our panel.
Thank you, Louise, and hello, everyone. Thank you for joining us today. I am going to share my screen to pull up the Primary Care County Data Explorer and spend the next 10 or 15 minutes walking through the data available and how to use the tool. Again, we'll have some time for questions about the Explorer tool specifically at the end. And also everyone is welcome to reach out after the webinar if you have additional questions or if you'd like to schedule a demonstration with our team. So with that, I'm going to share my screen. Okay. Put this in full screen. All right. So on our website now, which is live, and all of you should have received a link to the Primary Care County Data Explorer, um, which is, again, a second iteration of our primary care scorecard that we released last year, which you can also find linked on the same page. I am going to spend most of today walking through our workforce data and our new data that we have available by county. But I'll also briefly run through some of the metrics that we included in the scorecard last year, and kind of what's different in this new tool. So the way to navigate through this tool is we have our data stratified by our 5 different domains. So we have workforce data, access, metrics on access, performance, and health outcomes. And you can see all of these different sections displayed on top. You can click through to see the different sections. You can also use the arrow to scroll through. I'm going to spend the majority of our time today during this live demo on the first 2 sections, our workforce data and our metrics by county. So starting with our workforce data, we have available data on our primary care provider workforce across New York State. There are 2 different sections of data here. On the left-hand side, we have our primary care provider characteristics by county. And on the right-hand side, we have metrics on primary care provider supply. So I'm going to start with what we have here that reads primary care provider characteristics by county. There are 2 different ways to explore or interact with this data. Everything below is interactive. You can select a county from the drop-down menu to see all of the data below for a specific county. You can also click on categories within the graphs below to stratify further, which I will show you in a minute. But first, let me talk through what we have available in the graphs below. So starting on the left-hand side, we have a map of primary care provider practice locations across New York State. And so what we have available in this map is all of the practice locations where primary care providers are currently located. If you hover over the map, you can see the name and zip code of the facility and the number of primary care providers at that facility. The size of the dot or bubble on the map corresponds to the number of primary care providers that are located at that facility. And moving to the right, on the top, we have the number of primary care providers across New York State broken down by specialty. So we have 5 different specialty categories available here: general primary care, pediatrics, obstetrics and gynecology, behavioral health and psychiatry, and geriatrics. If you hover over the bars, you can see the number of providers and the specialty category. Below the number of providers, we have the percentage of providers that accept Medicaid for each specialty. So for example, we have 70.7% of behavioral health providers accept Medicaid. And then finally, below that, we have a pie chart of the total providers by primary care practice profession. So this looks within the specialties to see the percentage of each primary care provider that are physicians, so MDs or DOs, nurse practitioners, or physician assistants. So there are a few ways to interact with this data. I'm going to first show you how to look at this data by county. The default display is, of course, across New York State. If I wanted to look for data specific to my county, I'm going to go for Bronx here. And you can also select multiple counties at once, but for purposes of this demonstration, I'm just going to look at Bronx. Select your county, click Apply. And then all of the data here is stratified to the primary care provider characteristics for the county selected. So the map on the left-hand side is showing all of the practice locations in the Bronx. And on the right-hand side, we have the number of providers, the percent Medicaid acceptance, and the breakdown by profession. You can also look at this a few other different ways. So for example, let's say I wanted to just see the information displayed below for only providers with the general primary care specialty. I could click on that bar, and now we have just the Medicaid acceptance rate for general primary care, the percent of total providers by profession, and the practice locations where there are only general primary care providers. Similarly, if you want to reset that, you just click out of the graph. You can also press Escape if all else fails. Now, let's say I wanted to look at only behavioral health providers. I would click Behavioral Health, and now we can see that 87.9% of behavioral health providers in the Bronx accept Medicaid. Almost 40% are nurse practitioners. I can also look at this further for let's say I just wanted to see where the nurse practitioners are practicing. I could click that on the pie chart, and all of the other associated data stratifies further to behavioral health nurse practitioners. If I wanted to reset that again, I would just click out of the visual. Similarly, you can click on a facility on the map, and it'll show you all of the information just for that facility. If I wanted to reset this map, I would go back to the drop-down, click All, select Apply. You can also search for, if you don't feel like using the drop-down menu, you can also go to the map, click the little icon here, and type in, let's say Bronx, for example. And now that'll show you the information on the map for the Bronx. Okay. And again, all of this is interactive, and if you want to reset the map, always just press Escape or click outside of the graph. Now moving on to the data on the right-hand side, we have our primary care provider density, which is looking at the number of primary care providers per 100,000 residents. If you look at the drop-down menu, we have the primary care provider ratios broken down by a few different specialties. So for example, if I wanted to know the number of pediatric and family medicine specialty providers for residents ages 0 to 17, I would click that, and all of the information on the map changes for that specialty. The range is showing you the lowest value to the highest value. So for example, for pediatric and family medicine providers, some counties have none, and the county with the highest number of providers has 376.2 providers per 100,000 residents. On the map itself, if you hover over the county, you can see the county name, the rate per 100,000 for that county, and we also have available the specific definition for that specialty. Similarly, for obstetrics and gynecology, you can see that there are also some counties that have no providers, whereas others have 213 per 100,000 residents. Okay, so moving on from our workforce data, and again, I have this here in the little tooltip that pops up when you hover over all of the data displayed, but this workforce data is as of 2023 from IQVIA. So now I'm going to move on to our next section. Again, you can click the arrow or you can click the card. And now what's being displayed here are all of our metrics that we have available by county. We have data split up by access metrics, performance metrics, and health outcomes. And I will just walk you through what we have available on these maps. So if you go to the drop-down menu, you can toggle through a list of different measures. What's being displayed here right now is the percentage of primary care providers accepting Medicaid. The range will tell you the county with the lowest value and then the county with the highest value. So here, the county with the lowest number of providers accepting Medicaid is 62.7%. And there are some counties where 100% providers accept Medicaid. If you hover over the map, you can see the county name, the value, and the definition for that measure. Similarly, if you change the measure, the information on the map changes as well. And so now we have the different definition. The data year is also displayed below the name of the measure. And we also provide a note here to indicate which shade is performing worse or better. So for example, the darker shade is always a higher value, but here that would indicate worse performance, where a greater lack of health insurance is worse, which might be different than, for example, usual source of care, where the higher the value, the darker the shade is better. And this is the same for our performance and health outcomes. You can go to the drop-down menu to see the measures that we have listed here. And the data on the map will change below, as well as the year and any other information associated with that metric. And again, this page displays all of the data that is new from our scorecard, and different from our last year's iteration of our scorecard. We definitely are open to including new data, so definitely feel free to share any new data sources. All right, moving on to our next sections, I'm just going to quickly run through what we had from last year's scorecard. So this page is displaying our access metrics, which were some metrics that we had selected that look at the overall state performance that we thought were of note. So here we have the percentage of the population that has avoided care due to cost, and we have this broken up by race and ethnicity, potentially preventable hospitalization rates by race and ethnicity, usual source of care by county, and our pediatric preventable hospitalization rate. This is similar to what we had in our scorecard release last year, except we do have available here. If you hover over the visuals, it'll give you a little more information just on the specific definition for each metric. Moving on to performance, we have the percentage of folks with adequate prenatal care by race and ethnicity, core preventative services, the rate of early childhood vaccinations by county, and the percentage of folks with uncontrolled hypertension. Moving on to our health outcomes section, we have avoidable premature mortality by race and ethnicity, low birth weight, maternal mortality, and uncontrolled diabetes. So that concludes all of the data that we have in our Explorer. Again, we'll have time for questions at the end, so please feel free to drop them in the chat and we'll be happy to answer any of them. If we don't get to your questions today, please feel free to reach out. We will have a survey that pops up at the end of this webinar. And with that, I'm going to pass it off to Anna to lead our panel discussion.
Thank you so much, Angela. Hello, everyone. Thank you for joining us today. My name is Anna Popinchuk, and I'm the Director of Research and Evaluation at PCDC. First, I'd like to thank Angela again for her presentation, as well as her leadership in developing the Explorer. Part of the inspiration behind the Explorer was to help get data and evidence in the hands of people advocating and working on primary care. With that in mind, it is my pleasure now to facilitate a panel discussion to talk in more detail about how these data reflect the real-world realities of accessing primary care in New York, the relevance of these data to policymakers and clinicians, and why there is a critical need to increase investment in primary care. I'd like to invite our panelists to join us on video while I introduce them. First of all, Dr. Eric Gale is the Chief Executive Officer at the Institute for Family Health. Dr. Gale joined the Institute as a resident in 1996, and he has held a number of positions, including Chief Medical Officer, where he provided leadership and vision for all the clinical services, including medical care at the Institute. Over the course of his career at the Institute, Dr. Gale has championed quality improvement efforts and has remained committed to practicing family medicine. Dr. Thomas Green currently serves as the Chief Advocacy and Engagement Officer at Jordan Health Center. He is a distinguished executive leader dedicated to public service, equity, and community advancement, and has experience in executive leadership, operations management, and technology across government, nonprofit, and healthcare sectors. Through his work, he has championed transformative initiatives that uplift underserved communities in Rochester, New York. And last but certainly not least, we have Joe Tolano, who's PCDC's Senior Policy Manager, where he leads the policy team's initiatives with the federal government. Prior to joining PCDC, he spent over 3 years working on Capitol Hill for Congressman Mike Doyle, where he advised the congressman on health-related policy issues. So thank you to the three of you for being here with us today. The format of the panel will be a series of questions, but I encourage the panelists to feel free to chime in and respond to each other if they have additional thoughts. Similar to the presentation before, we will hold all audience questions until the end, but if you have a burning question, please feel free to use the Q&A box and we'll get to it when we get to the Q&A portion. So our first question is to Dr. Gale. The Explorer highlights the barriers, including cost, Medicaid acceptance, and health insurance status that currently exist in accessing primary care in our state. To start us off, it would be great to hear if these barriers are a concern at your health center and FQHCs generally in New York. And what does that look like in terms of wait times to get an appointment, or how long it's been since your patients have last seen a doctor, and other examples that you see when providing primary care in your organization and communities.
Thank you, and I'm really happy to be part of this conversation with my distinguished colleagues at the panel. Those are certainly questions that patients may have when they're looking to access services in our health center and in any health center across the state. But, fortunately, the question about their health insurance status, their Medicaid insurance, as whether or not those are barriers for them accessing care, isn't one that I think would prevent them from accessing services. I think the biggest challenge that I see from practicing in the Bronx for the last 30 years is that we just don't have enough providers, and that causes patients to wait a lot longer to access services, even if they have private insurance. I mean, we're seeing patients might be waiting up to 60, 90 days to get into the office to get care. Now, we do accept walk-in services and we do try to do the best we can in terms of providing same-day access. But for the majority of patients, when they're looking to establish care and get continuity of care, the wait time is significantly longer. And what that does is impact their ability to have their health continue to be elevated and be as controlled as best as possible.
Thank you, Dr. Gale. And that flows seamlessly into the next question that we had for you, Dr. Green, where, Dr. Gale just reflected on the lack of availability of providers. And if we looked at the map that Angela was showing, it actually looked like there was a greater concentration of providers here in the city than upstate. And we really see those geographic disparities across the state when it comes to the primary care workforce. So if that is what Dr. Gale is experiencing in the Bronx, what does that look like day to day, and what are those implications for upstate practices, and if they are facing any workforce shortages?
Yes, first of all, thank you for inviting me to be a part of this panel. I'm really honored to be here with my colleagues and the fight against disparities and making sure that we have equity in healthcare. There are a lot of barriers, and certainly primary care is a large one of them that can be seen in the data points that have been showed in the presentation have given here. And as we all know, that the delayed diagnosis that happened as a result of not having a primary care provider or being there for those diagnoses makes an over-reliance on our emergency departments, and in a lot of cases makes it such that people's or patients' issues have been moved forward and not addressed in a timely manner. So many of our patients come in and they have multiple unmanaged chronic conditions and social needs and mental health concerns. And so being able to have the primary care provider to be there for the patient is very important. And when there is a shortage of them, then we see that we can have long wait times. In our case, our wait time for new patients is twice as long as our existing patients. So we have to make sure that we address those, make sure that our lawmakers and our policymakers understand the importance of making sure that we invest in our primary care providers.
You guys are making my job easy and just seamlessly transitioning us through the new questions. Speaking of policymakers and advocates, Joe, the data from the Explorer really underscores how underinvested primary care is throughout New York State. And I'd love to hear from you what efforts by lawmakers in Albany are happening to address this, and how do these data help make the case for increased investment?
Absolutely. Thanks, Anna. And thank you, Dr. Gale and Dr. Green for joining us today as well. So as Louise mentioned at the top of the presentation, there's the Primary Care Investment Act. This is a bill that's currently introduced in the New York State Legislature by Senator Gustavo Rivera and Assemblymember Amy Paulin, who are both chairs of their respective chambers' health committees. If enacted, this bill would measure the current level of primary care spending in the state by private and public insurers, require the state agencies to make that information public, and then require insurers that report less than 12.5% of their overall health spending on primary care to increase that investment 1% each year until they reach 12.5%, and to spend those funds on supporting primary care services and strengthening the state's primary care infrastructure. And this increased investment in primary care has the potential to make care more accessible, increase the number of providers, as Dr. Gale and Dr. Green were referencing earlier, and support those providers that provide a full range of integrated services in the most needed underserved communities. All of this while reducing overall health costs over the long term. I mean, the reality is that primary care has been underfunded for years. Nationally, primary care only accounts for about 35% of all health. Nationally, primary care accounts for approximately 35% of all healthcare visits each year, yet only about 5%, 7% of all healthcare expenditures are for primary care. And while there's no public data on primary care spending in New York, there's the average percentage is estimated to be about 6% throughout the state. And I believe the data that the Explorer presents really reflects this and can show how lawmakers, how underinvestment in primary care is affecting the counties overlapping in their own districts and communities. And New York is a big state. Dr. Gale and Dr. Green both said this earlier, that this is an issue affecting every region, and the Explorer proves that. And really, when looming federal cuts coming for federal cuts in Medicaid, that preliminary CBO score estimates will result in more than 8 million people across the nation losing their health coverage, meaning that more of our most vulnerable in our society will lose access to preventative primary care services. This really underscores the urgency and need for lawmakers to take action now.
Thanks so much, Joe, for that overview, and it's great to hear the efforts that are happening. This question is for all of you, but I guess primarily for Dr. Gale and Dr. Green. Thinking of the Primary Care Investment Act and the possibility that it offers, if you had more to invest in primary care in your organization, what would you spend it on? What would be your priorities? Technology, additional staff, facilities, specific programs? We'd love to hear what kind of comes to top of mind.
Yeah, thank you, Anna. I think, we spent the last year advocating at the state level for more investment in primary care and in community health centers. And, the wish list for us would first start with getting our workforce in order. I mean, the tool is underscoring where our deficits are in access across the state. And, we also have, as the Institute also has centers up in the upstate section of New York. And we're a training program. We train family medicine residents. We train nurse practitioner residents. We can't even recruit our own because they are seeing that the investment in primary care is not worth it for them to stay in the areas that they're training and can provide quality services. So this is something that challenges us. So I think any investment that we can get from the Investment Act would help us with our recruiting. I think it will strengthen the primary care networks and expand the amount of services that we can provide in our health centers. And I think it would help also the health insurance companies to want to invest more in the front end for primary care, so that they can see that savings on the back end. Dr. Green already spoke to what it's going to look like if we're not making investment upfront, where it will impact tertiary care and hospitalizations and so on and so forth. So I think if we can get some investments in primary care, I would love to have the opportunity to know what I could do with additional investment in primary care, because I do think we can expand services and expand our workforce and keep those providers who want to stay in primary care tied to the communities they're already training in. Dr. Green?
Yeah, I agree with Dr. Gale's 100%. And we know that if we invest in primary care, that it saves multiple dollars downstream, and more importantly, it will save lives. Workforce is very, very important, and being able to have a primary care provider. And let me take a step back and just talk about my experience in growing up as a young person in the inner city and having a primary care provider. My primary care provider was Dr. Charles T. Lunsford, the first African-American doctor in the city of Rochester. And we were fortunate that we had that primary provider, care provider, and we had access to them. And then there did come a point where, again, that one provider was trying to provide services for so many of us in the community who at that time really didn't have transportation to get the other providers that were other places. So the benefit of having a provider and to be able to get to them, again, it saves that funding downstream for us flooding the emergency rooms. I can't tell you how many places that I've seen where the emergency room now has to be expanded. COVID was one thing in expanding that, but now and before there was this need to expand the emergency rooms, and people were flooding in there as their first level of support, when if they had only had a primary care provider and had access to that primary care provider, a lot of the conditions that had grown had become costly would have been prevented in the first place. So we just got to make sure that we are able to, again, educate our lawmakers that 6% is not going to be what is needed to reduce the cost downstream.
And to going off what Dr. Green just said, I mean, we speak to lawmakers across the state all the time and really try to hit home that primary care is the only part of the healthcare system that saves money. It not only has been proven to save costs for the state and providers, but also to lengthen lives as well. Because as Dr. Green was saying, that if more folks have access to a primary care provider in their own community, they will be less likely to develop more acute conditions down the road and less likely to have to seek emergency services.
Yeah, I would just add one more point to Joe's comment, is that think about what could potentially happen if we see a larger investment in primary care in this state, and what that could mean to the country if we're able to successfully do that and see some of those areas that the tool was showing us where there is gaps in primary care being filled in by clinicians who are looking to serve. I think that would elevate our need to the highest levels, to Congress, to say this is something that is showing that we can actually provide access in resource poverty areas by just doing a lot more investment. And I think this is an opportunity. This tool is giving us data at the granular level where we can see what is actually happening at the ground level in terms of people being able to access services and improve their health outcomes, as some of the data is being shown from the tool.
Excellent. Thank you all for those reflections. And I think it's such an important point that, primary care has such an impact on reducing costs elsewhere in the health system, but also really does improve health outcomes and population health overall. Joe, we have a little bit more time, and I would love to hear if you could provide a little bit of some context of, New York has this Investment Act. What's happening in other states? Have there been other states that have been working towards increasing investment in primary care, and what can New York learn from them, if anything?
Absolutely, yes. So the Primary Care Investment Act isn't a unique piece of legislation. Other states have passed similar legislation or have instituted similar policy through regulatory action at the executive level in their respective state. For example, this past year, California, through in a regulatory change, instituted I believe a 15% requirement investment in primary care. So I mean, most of that has happened within recent years. So the how that has affected the primary care landscape in the state still remains to be seen. But I think that New York legislatures can look to other states, look to other large states like California, and see that this is doable and possible, and other lawmakers across the country are taking notice.
That's great. We did have one question, which if we're on this topic already, I'm going to break my rule a little bit because one attendee did ask, can you speak more about the bill that PCDC is developing? So Joe, if you could just provide maybe a little bit more detail about the Primary Care Investment Act, we can talk about that and then we can close with our final question.
Absolutely. As I mentioned, this is a bill currently in the New York State Legislature, sponsored by Senator Gustavo Rivera of the Bronx and Assemblymember Amy Paulin of Westchester. The bill would, as I mentioned, require insurers to spend at least 12.5% on primary care services, and then increase, if they're already spending below 12.5%, increase 1% year to year until they meet that threshold, and would also require measurements of primary care spending in New York State, which is currently data that is only estimated in the state, and we don't have concrete data. Currently, the bill has been passed out of the Senate Health Committee. It is now in the third read in the Senate, and hoping to see a full Senate floor vote soon. And is currently in the also being considered in the Assembly Insurance Committee as well.
Anna, can I go back to a question you asked, if you don't mind? And I gave the answer in terms of the workforce, or what's important and what would you invest in. But as we think about AI and technology, I think that that's important for us to also make sure that we let others know how important that is, whether it's using telehealth or mobile units to be able to get to people. AI it has its place. And so I think as we look forward and we look at all of the different technologies that are available or that will become available, that we understand that we need to invest in that, and also invest in bringing along educationally wise some of our doctors and primary care providers that will be here for us in the near and far future. So I think that those are the things we should also keep in mind in terms of what other type of investments we would want to make.
Yeah.
Absolutely, that's a really good point. And bringing up telehealth too, as we know, was such an important way to increase access, especially during the pandemic, but payment parity wasn't on par for those services. And so making sure that if we're looking at all different ways that we can use technology to increase access, but also ensuring that those services are reimbursed in the way that they need to be, so that we can all keep providing the care that we know is vital for our communities. Well, we have a few minutes now before we switch to the Q&A, and I would just like to invite everyone to provide some closing reflections. A year ago, we released our primary care scorecard, and this year we've released the Explorer to dive down into this county level data. But I would love to hear from all of you. Where do you hope that we will be in a year, whether that is around the legislation or primary care access or new research around primary care? Let's look towards the future. And I know that things are difficult right now, and there's a lot of uncertainty around Medicaid and things, but where do we hope to be a year from now when it comes to primary care in New York? And what else can we be doing to make that possible?
Well, I would hope that we're not having this conversation again about the state investing in primary care. That would be the dream. And I do hope when we look back on the using this tool and reflect on whether or not we got passage of the bill that invested in primary care, that we're seeing some of these resource poor areas beginning to fill in, even if it's a new dot that's added to that. So I think I would like to see the trend, if there's an investment in primary care, if we're doing a much better job in filling in those areas of need for primary care services. So that would be a welcome change for us in this next year as we look to continued conversations with our legislatures.
That's a great point, and I think underscores part of our reasoning for these tools too, was to really establish a baseline for us to be able to track any policy change in the future. So Dr. Green, please go ahead.
Yeah, I'm sorry. Yeah, so I look forward to a future where patients have timely access to primary care, where we've removed all of the complications and that people are leveraging the emergency room less and less. So I have the privilege of working at Jordan Health, which is named after the second African-American clinician in Rochester, and our leader, Dr. Linda Clark. But we are very, very strong in trying to advocate for health equity within our community. And I would hope to see that across all of our nation. And I know that unfortunately, while COVID brought some challenges to our patients, now we have some changes coming as a result of administrative changes. And as a result of that, there are people who are fearful to come in because of immigration changes. We're losing some funding for places like AmeriCorps, and we know that we have the attack from our Medicaid. And so when we look at all of the things that are affecting our marginalized population, one of the things that we need to make sure is that we're able to get them where they need to be in terms of getting primary care or other type of services that are going to help them to get past these changes. So I hope that we'll be able to make the investments in primary care that will help with all of the complications that we see going along.
And not to repeat what was already said too much, but I also hope that within the next year, the Primary Care Investment Act is passed and signed into law. I think that's something that has been consistent in our conversations with lawmakers and their staff, is that when we immediately bring up the fact that it's difficult for anybody to find a primary care provider, regardless of what kind of insurance you have, everyone can relate to that. Almost universally from every district that we've met with across the state. And I think that the data presented in the Explorer that we presented today will continue to reflect that reality, and hopefully over the next year continue to grow the sense of urgency among lawmakers and their staff.
Thank you to all three of you for your reflections and for your time today. I'd like to welcome Angela to join us for the Q&A portion. But as she does that, we had a couple questions in the Q&A. One was, what do you think the impact of the Career Pathways Training Program will have in the next 3 to 5 years in terms of workforce? Dr. Green or Dr. Gale, do you have any reflections on that?
Yeah, I think it would only help. It's not only a deficit in clinicians or physicians that are challenging access. It's also a pathway for other individuals who want to participate in the healthcare system to be able to get into the healthcare system and help meet the needs of the communities that we're looking at. So I think that if that also gets passed, it can only help our workforce challenges. I think Dr. Green and I are not just saying that there are challenges is on the clinician side, it's also on the nursing side, on the medical assistant side, and so on and so forth. So this can only help us get better. One of the things that clinicians are looking for is, are they going to have the support they need in order for them to focus on providing direct care? So I think this is something that would help us all together.
Absolutely. I agree with Dr. Gales. And we look at that support staff, and we also have to look outside of our healthcare domain and the challenges with other fields and areas where we have to be competitive with salaries. We have to be competitive with benefits that people are getting in order to keep them within this realm to be able to support the doctors. So whether you're MA and those laws that are looking for them to do more, whether it's telehealth and allowing us to be able to leverage those services, or LPNs that we're trying to get into the market, RNs, whoever it is, we just need to do what we can because there is an outside force that we have to be conscious of. And people have options of where to go. I've seen some people who talked about them going over to work at a sandwich shop where I can make more money
Yeah.
and where the benefits are better. And so we've got to be competitive.
Absolutely. Thank you for that. Joe, one question for you. Someone asked, is the Primary Care Investment Act different than the Pay PCPs Act?
The Pay PCPs Act, I believe, is a federal piece of legislation. I could be wrong though. But I'm not totally familiar with the provisions of the difference of the provisions of those two bills. But as far in the New York State Legislature, the Primary Care Investment Act is the only piece of legislation that would require insurers to increase their spending to 12.5%, as I outlined earlier.
Excellent. And for those of you, there were a lot of specific data questions around the workforce data and how we collected the data for the Explorer. Angela has answered all of those in the Q&A section itself, if people are curious. But Angela, I don't know if you want to provide a quick overview of kind of some of the information that you were just sharing with others who might not be reading the chat.
Sure. So I did put in the chat a link to our technical appendix, which lists out all of our data sources and some of our methodology and how we process the workforce data. I did have a question about the for the primary care provider data, some questions around how to access things by different specialty. And let me share my screen really quickly just so I can hopefully answer that. So there was a question around if we can find primary care provider data by county population. And so that should be found under this primary care provider density section, which looks at the number of providers per 100,000 residents. And we have this available by these 5 different specialty categories. There was also another question, I believe, about if we're able to analyze this data for the entire workforce, but just excluding OB/GYN and behavioral health providers. Currently, the way it's here is we just have the data separately by each specialty. So there's not a way in here to, I guess, add up if we wanted to look at, for example, I'm assuming that question would be around looking at the primary care workforce, but including this data for pediatric providers and providers with a geriatric specialty. You would have to click on those each separately. But I will say if there is something that you're looking for specifically that you can't quite get here, definitely feel free to reach out and we'll be happy to provide what we can if it's possible. And it'll also just be good to know for us on our end, as we do future iterations of this, what data is really most useful to provide. I think we went back and forth a lot on, especially for the workforce data, how to kind of break this up by different specialties, because as we know, primary care can be defined many different ways. Sometimes we include behavioral health, sometimes we don't. So we'd definitely like to hear more about what would be most useful for people. We do plan to update the workforce data next year to be current as of 2025. And so we definitely would appreciate different perspectives on how to define that. And in the meantime, again, feel free to reach out because there might be something, if you're looking for data specific to your county, we would be happy to provide it if we have it available.
Thank you so much, Angela. It looks like we don't have any other questions. So I just want to take the time to thank Dr. Green, Dr. Gale, Joe, and Angela for your time, for your reflections, and for your expertise today. It's been a great conversation talking about primary care, why it matters, and why we need to invest more in it. Thank you everybody for joining us today. We're so thrilled that you could be part of this conversation. We've linked the relevant resources that we discussed today in the chat, but at the end of the webinar, we also invite you to fill out a short survey, one to give us feedback on this programming, but also, as Angela said, we've given you all the opportunity to share your contact information if you want to find out more information either about the bill or the tool, because we want to be a resource for all of you so that you can use these data to really advocate for primary care and make a difference in your communities. So thank you again for everyone for joining us, and I hope you all have a wonderful rest of your afternoon.
Thank you, guys. Enjoy your rest of the day.
Thank you.
Thank you.